Hi, my name's Corey. This is my video portion for my assignment on ADHD in Nursing 730. The case scenario describes a 9-year-old boy whose mother brings him in to see the care provider and is really struggling with Chayton's symptoms and behaviors. So a brief description of the ADHD is primarily a neurodevelopmental disorder characterized by delayed maturation of the prefrontal cortex, as well as an imbalance of the neurotransmitters, specifically dopamine and norepinephrine. This chemical and structural difference in the brain leads to deficits in executive functions, causing difficulties with sustained attention, impulse control, and emotional regulation. The medication that I chose for Chayton is Adderall. It's an effective choice, which is a CNS stimulant. It's the first-line treatment option for children age 6 and older, which is why I chose it. It works through boosting key neurotransmitters, so it gently blocks the reuptake of dopamine and norepinephrine, increasing the availability of them in the prefrontal cortex. So this area of the brain is responsible for planning and focus. Adderall also improves signal clarity by increasing the brain chemicals, and it just makes things a lot more tangible and clearer, the signaling to be clearer. It allows for the affective neural networks to communicate more efficiently so that the patient, or in this case, so Chayton, can pause, think, and regulate their responses rather than acting so impulsively. Adderall has a long history of significantly reducing symptoms of inattention, hyperactivity, and disruptive behaviors in children. There are immediate release for Adderall. There's also the extended release formulas, which can provide up to 10 to 12 hours of symptom relief, which is what I would prescribe for Chayton. I decided to choose a response to scenario 1, which is talking about how Chayton's coming in with the complaint that the medication is wearing off too soon, and what to do if it's wearing off at noon and it needs to be lasting a lot longer. So when a stimulant like Adderall wears off too early, it does cause a sudden crash, which manifests into lethargy, irritability, and indicates that the medication is metabolizing much too quickly. So I was thinking that why not either increase the morning dose, which would increase the concentration of medication in the bloodstream during the first few hours. Or we can either add a booster in the morning. Okay, let me rephrase. Do a shorter dose in the morning and take the extended release at lunchtime, which would cover the next 10 hours, or you can switch it around and do the bigger dose in the morning and then do the short dose at noon. So the AACIP, which is the Adolescent Psychiatry Attitude Magazine journal, it recommends adding a small, short-acting, immediate release dose just before the morning dose wears off. So that's also another way to bridge, and that creates a smoother transition, preventing the afternoon crash, and maintains symptom control for after-school activities and homework in the evening. So there's options for that scenario. And then there was the next question for this video. It asks about how, as a PMHNP, as a care provider, how do we balance clinical judgment, requiring treating the therapeutic alliance as an active intervention. So I came up with harmonizing with the neurobiological expertise that a PMHNP has, and then blending it with patient-centered needs. This would be a good way to build a flexible framework that accounts for the cognitive, emotional, and social limitations that a patient would be presenting with ADHD. Let's see here. Research has showed that enhancing patient motivation to want to get better results, have a better balance with their symptoms, and applying it to everyday life, that's more effective to get the patient motivated than really speaking in terms that the patient doesn't understand and not relating. So there's shared decision making and autonomy, which when you have a 9-year-old child, you're also communicating mostly with the parent or the person that's taking care of them and overseeing them. So you kind of have like a dual communication opportunity there to really relate to Chayton and what his goals are. His goals are maybe not to feel like he's getting in trouble so much, to give him more control over his decisions and abilities, rather than communicating with, in this case, his mom and saying, look, this is why we're doing this. There are side effects, but this is why. So getting into my own personal beliefs and biases, which we all have them, understanding that ADHD is a neurobiological disorder, fundamentally can shift the provider's perspective from behavioral judgment, like why are you not able to do this? This is no excuse, to more of a medical understanding of why this is happening. I think this paradigm shift minimizes personal bias. It transforms maybe frustration into clinical patience. It deepens empathy as a provider. It eliminates the fear of maybe being an enabler, and replaces stigma with realistic evidence-based hope for treatment. Historically, ADHD has been very stigmatized as a lack of willpower, poor parenting, or even laziness. So learning that it involves altered frontostriatal brain networks, delayed internal clocks, and dysregulated dopamine and norepinephrine pathways, it really removes this bias of choice that a patient has from the patient's symptoms. So that's very enlightening to have that understanding when treating these patients. How do my feelings get in the way as a provider? I would think that my comfort and discomfort level determines whether I present a medication with a risk frame or a benefit frame narrative. So if I am nervous about the side effects, how I feel about that will be portrayed to the patient and caregivers. I might inadvertently use more severe language or disproportionately focus on adverse events if I have certain feelings about it. And that can produce effects or unjustified just kind of dread in the patient. So I can also omit things maybe that I'm not realizing I'm omitting. And so I just have to be really careful about how my feelings get in the way about certain behaviors, and how the medications work. Let's see. I wanted to talk about how to deal with patients who don't adhere. Adherence is, I think all people struggle with adherence at some point or another, and a clinician might feel frustrated or helpless, or have these ideas about being able to rescue a patient from what they're going through. These can also lead to conclusions or assumptions that the patient then is resistant, and so then we have that working around a particular patient or patient population, and all of those feelings and ideas directly conflict with the neurobiological realities, like executive dysfunction, dopaminergic dysregulation, dopaminergic dysregulation, and yes. So managing these complex psychiatric cases, it will naturally evoke a specific counter transference and emotional response. So I'm just being aware of that, maybe getting the support that I need, to just, awareness is everything. Frustration and impatience can happen when I'm spending considerable time educating a patient and family, only to find that they didn't even take their medications or take any of it seriously. So anyway, I'm learning about these things as I'm doing these homework assignments, and realizing that how I feel about like a condition like ADHD, how I feel it should be handled, my biases and personal experiences. I know both of my children, who are now adults, had ADHD, and so I have also that experience of being on the other side and supporting them the best that I could. So awareness of where I stand, and also continuing my education about the latest evidence-based practice around it. I'm really drawn to working with people who have ADHD, so I'm very interested in that, and just being the most educated and non-judgmental provider that I can be. So anyway, thank you so much. This has been long enough, and until next time.